So in this chapter 8, we've been talking about neuropathic chronic pain, pain matrix dysfunction, and we talked a little bit about fibromyalgia. So in the last section, it's amazing that I've actually managed to keep each section to right at about 15 minutes, maybe a little bit over, maybe a little bit under, but trying to make it easy for you. We're going to talk about some other pain syndromes, some types of headaches, red flags for headache, which is important because people come into physical therapy, they have a headache. There's some things that we need to refer them to their doctor right away and make sure that something gets addressed. So we're talking about a couple different types of headache and some other pain syndromes, and then just some ideas around our goals versus the patient goals when it comes to chronic pain. So the first type of headache we're going to talk about is called episodic tension type headache, or ETTH. It is usually mild to moderate pain, usually bilateral, and this is as opposed to migraine, which is usually unilateral. ETTH can last from 30 minutes to 7 days. It's not aggravated by physical activity, as migraine often is, and it's not associated with nausea or vomiting, which migraine often is. It can include photophobia or phonophobia, which is sensitivity to light or sensitivity to sound, but usually not both. Sometimes migraine has both. The mechanism for ETTH appears to be super sensitive to nitric oxide, which nitric oxide is a molecule that's used in the transmission of nerve impulses that sensitizes nociceptive pathways in the central nervous system. So the 1-year prevalence of ETTH is 87%. Environmental factors appear to be much more important than genetic factors, such as volatile organic compounds, fumes from paint, lacquers, and plastics, molds, lighting, noise, excessive heating or air conditioning, and psychosocial pressure. So interesting phenomenon, and you can see where it's distinct from migraine. So that's what I want you to get out of this. If I gave you some headache symptoms, like it's bilateral, and here's how long it lasted, and here are the associated symptoms, I would like you to be able to identify whether it's a migraine or an ETTH type headache. Migraine is a neurogenic disorder. So disorders of sensory processing produce a pain matrix malfunction that amplifies nociceptive signals in the trigemino-thalamocortical pathway. So it's a pathway leading from the cranial nerves to the thalamus and the cortex. So it's characterized by at least 2 of the following symptoms. Unilateral location as opposed to ETTH, which is bilateral, a pulsating quality, severity interfering with daily activities, so it's often aggravated by irregular activities and aggravated by routine physical activity like walking your dog, taking care of your kids, getting out of bed. So that sort of thing. So migraine is something that can be triggered by it's largely influenced by genetic factors. There's a sort of a cascade of events that happen in a migraine. So there can be some kind of trigger, like bright light, loud noise, excessive prostaglandins in the periphery, emotional stress, hormonal changes, specific foods or drinks, like some people, if they eat chocolate or red wine, it can trigger a migraine, or meteorologic, so weather changes can trigger a migraine. Once it's triggered, you get excitation of hyperexcitable brainstem neurons, and that affects your cranial nerve pathways. Only in people who experience an aura. So some people experience an aura, which is a sensory effect that precedes the migraine. So when people experience an aura, there is a wave of intense neural activity spreading through the cerebral cortex, particularly the visual cortex. So that's when people get the visual aura. It's followed by widespread and prolonged neural inhibition. So a lot of people know when a migraine is coming on if they experience that aura, and they can actually take, there are some pretty effective medications like Imitrex is one of them, that can help stop the migraine at that point. So after the aura, the hyperexcitable brainstem neurons, activation of trigeminal afferents that synapse with the trigeminal lemniscus neuron. So we haven't talked about that pathway, but it's similar to the somatosensory pathway, but it's just the cranial nerve. So those trigeminal lemniscus and thalamocortical neurons become sensitized during a migraine owing to pain matrix malfunction. So there's a graphic in the book that shows the sequence of events in migraine, and it's on page 155. There are sometimes aspirin or a combination of aspirin, caffeine, and acetaminophen can stop the headache if taken at onset. So there's actually Excedrin migraine is an over-the-counter medication that includes those things, and a lot of people with migraines find that to be a very useful treatment. Serotonin agonists, there are several of them, can reduce neural activity in the trigeminal lemniscus and the thalamus. Imitrex is one of those. I have talked with people who've had good results for reducing the overall number of migraines with craniosacral therapy. So it's a manual therapy. It's a very subtle, gentle manual therapy, but that is something to look into as well. So what we're looking for in the red flags for headaches, someone comes into PT and we want to make sure that the headache is not caused by something that they need immediate medical attention for. So if the headache it can be caused by excessive pressure in the brain, hydrocephalus, which is excessive fluid in the brain, or a tumor. These are the red flags for that. Headache present at waking. Pain triggered by coughing, sneezing, or straining. Vomiting, but that may also indicate a migraine in absence of the other red flags. And the symptoms worsen when lying down rather than getting better. So that might be caused by excessive pressure, or hydrocephalus or a tumor can cause excessive pressure. So signs that a headache is caused by serious intracranial disease, tumor, encephalitis, or meningitis include the following. Progressive symptoms that worsening over days or weeks, neck stiffness and vomiting, and the vomiting is caused by, the vomiting and the neck stiffness are caused by irritation of the meninges. A rash or fever can be caused by bacterial meningitis or Lyme disease. A history of cancer or HIV infection. So if people have these headaches progressing and worsening over days or weeks, really refer them back to their doctor. There's probably not a physical treatment that we're going to be able to do with them that's going to change a tumor or encephalitis or meningitis, and it's certainly not going to change hydrocephalus, and that might even make that worse, or a tumor. So they need to be referred back to their doctor when they have those signs. Signs that a headache may be caused by hemorrhage include the following. Headache after a head injury. That's a good indicator. Abrupt onset. Headache associated with onset of paralysis or reduced level of consciousness. So confusion, drowsiness, memory loss, loss of consciousness. They need to get into the ER and they need to get a CT scan or an MRI done on their brain, because it can develop into a hemorrhagic stroke. It can kill them or cause severe after effects. They might even need surgery. If it's headache after head injury, they could have a subdural hematoma. We'll talk about vascular events and head injuries in chapter 19. But if somebody comes into PT and has any of these red flags, we need to refer them for immediate imaging. So chronic whiplash-associated disorder. Whiplash is an injury to the neck that results from rapid acceleration or deceleration. It usually happens in a car injury or a vehicle injury of some sort. There's usually no damage to the somatosensory system with chronic whiplash-associated disorder. It's considered a pain matrix disorder. So obviously with acute whiplash, there's a physical cause for it. There's a somatosensory cause. But when it becomes chronic, that's when it's the pain matrix dysfunction. So a lot of there was one study that was mentioned in the book where 34% of whiplash had predominantly neuropathic pain, rather than nociceptive pain. The group with neuropathic signs had greater pain, greater disability, cold hyperalgesia, so they were hypersensitive to cold, and cervical mechanical hyperalgesia, meaning they were hypersensitive to having their neck moved, and less elbow extension with brachial plexus provocation tests. So the rest of the people, the 66%, had nociceptive pain, and they didn't have all those symptoms. But there are no differences between the two groups in terms of pressure pain thresholds and psychological distress. But because there's no damage to the somatosensory system, it is considered a pain matrix disorder. So, two syndromes that involve other symptoms in addition to the pain matrix, the pain system, are complex regional pain syndrome, which involves somatosensory, autonomic, and motor systems, and chronic low back pain syndrome, which involves muscle guarding disuse and abnormal movements. So we'll talk about each one of those a little bit, and these are the pathology boxes from the book. So complex regional pain syndrome is a syndrome of pain, vascular changes, and atrophy. It used to be called reflex sympathetic dystrophy. That's kind of the old name for it. But the term regional indicates that the signs and symptoms present in a regional distribution rather than a peripheral nerve or nerve root distribution. So it's going to be like one upper limb or one lower limb rather than a peripheral nerve distribution. So usually the signs and symptoms are worse distally, and they affect either the entire hand or foot. And it's sort of an aberrant response to trauma. Even minor trauma can cause complex regional pain syndrome. So a lot of times it's following a surgery, a fracture, a crush injury, or a sprain. In a really small amount of cases, less than 10%, it occurs spontaneously, like there was no injury that brought it on. The time between the trauma and the onset of complex regional pain syndrome is variable. It could be right away, hours later, or weeks later. So I've worked with people who've had surgical fixation of an ankle fracture that developed into complex regional pain syndrome. We treated them with aquatic therapy. It was very helpful. I've had people who had, I had one woman who had an arm injury, and I think it was a repetitive strain injury, if I recall correctly. It was some years ago, but that developed into complex regional pain syndrome, and we also treated her with aquatic therapy. So kind of interesting. The early signs, the skin can be red or pale, excessive sweating, edema, and skin atrophy, and that is the autonomic effect. Later on, the skin becomes dry and cold, and the joints become stiff and swollen. If it progresses to its later stages, you can have irreversible muscle atrophy and even osteoporosis and arthritic changes. So there might be some motor signs, paresis, which is partial paralysis, spasms, and tremor. So there's a diagnostic criteria for complex regional pain syndrome. There's a little box in the book. They have to have continuous pain that's disproportionate to the inciting event, at least one symptom in each of the following categories, and one sign in two or more of the following categories: sensory, vasomotor, pseudomotor, or motor or trophic changes. So sensory is like allodynia, hyperalgesia, or hypoesthesia, where they have a numbing sensation. Vasomotor, which is a temperature or skin color abnormalities, and there's a picture in the book, and you kind of see those skin abnormalities. Pseudomotor, which is edema or sweating abnormalities, and again, that sweating is an autonomic response. and the motor abnormalities, muscle weakness, tremor, and hair, nail, and skin abnormalities. Interesting, right? So that's sort of an interesting symptom. There are some medical drug treatments for complex regional pain syndrome that they talk about in the book. Sometimes electrical stim, or the things that I've done with the few people I've seen with it have been desensitization and aquatic therapy, really useful for that. Chronic low back pain syndrome. So compared to people that have no back pain or other types of low back pain, chronic low back pain syndrome people have more emotional stress and less endurance of abdominal and back muscles. So the transition from acute low back pain after an injury to chronic low back pain is supposedly a change in the etiology of pain from tissue damage to physiological impairment. So there's muscle guarding, abnormal movement, and disuse syndrome. But all of the studies that have studied chronic low back pain syndrome show that exercise is a very effective treatment for chronic low back pain syndrome. But it's challenging to get people on board with that. And I'm telling you, if you work in outpatient therapy, you will see a lot of low back pain. That is a very common outpatient diagnosis. So there's surgical treatments for chronic pain. I'm not going to talk about them too much. They're mentioned in the book, but obviously we don't do surgery. We do physical therapy. A lot of times there are a lot of studies about how effective surgical treatment of chronic pain is, and it's actually not very effective, unfortunately. So obviously there are some psychological factors. Well, I talked about with the therapeutic neuroscience education, expectations, cognition, and emotions all affect the experience of pain. Anxiety, depression, and catastrophizing predict reactions to pain and the ability to cope with pain. The amount of pain an individual expects influences processing in both the medial and lateral pain systems. So the interesting thing that I see a lot of times, we get people, we have our joint replacement program at the clinic where I work. We have people that come in for one knee replacement, and then 6 months, a year, 2 years later, they come in for the other knee replacement. By and large, the people who are coming in for their second knee replacement have a much easier time of it. They don't have as much pain, they gain their range of motion faster, and I think, my theory, unsubstantiated of course, but is that people's expectations are better. They recovered from the first knee surgery. They had great results from it. So now they have great expectations. And their expectations are better. They know it's not a catastrophe. They react better to, they don't have anxiety and depression associated with the pain, and so they get better faster. I've seen it numerous times over and over again, and I think it's pretty cool. So the therapist has to address all 3 Ds of chronic pain: distress, disuse, and disability. So we have to assure the patient and teach them about their pain, and that's going to help. We have to teach them exercise to combat the disuse, and we have to help them do things that they're unable to do at this point, and that's their disability. So psychological interventions may also decrease activation of the pain system and improve coping skills. So relaxation, biofeedback, imagery, and cognitive behavioral therapy. As part of our chronic pain program at my clinic, we do relaxation and biofeedback and imagery, as well as addressing other psychological factors. Placebo-associated improvement is defined as any genuine psychological or physiological effect which is attributable to receiving a substance or undergoing a procedure but is not due to the inherent powers of that substance or procedure. So if I give you an exercise that just makes you feel better because you're finally doing something, but it doesn't actually have any effect on your pain, it's a placebo. Or if somebody gives you a medication that does the same thing. The psychological factors that we can use to approach chronic pain is positive yet honest communication about the therapy. So tell them, hey, this is going to help. This is great. Give them that encouragement, and education is a huge, huge, huge piece of it. Developing trust, compassion, and empathy with your patient. I've had patients come in and they say, well, I went to another PT clinic and they just made me feel bad for being injured. And I don't, that's how they perceived it. And so giving them a little bit of trust, compassion, and empathy goes a long way for them getting better. Understanding the person as an individual. What are their individual challenges? And creating rituals that provide meaning and expectancy for the person. Give them goals that are achievable. Give them suggestions for things to do. Giving them positive steps that they can take to make themselves feel better can have a huge psychological factor in helping with chronic pain. Sometimes people with chronic pain want healthcare providers, or the main thing they want is they want the healthcare providers to acknowledge them as individuals and to have their pain recognized as biologically based. I've had so many people say, the doctor thinks the pain's all in my head. And I think that's a perception, but they don't want that. They want to know that there's something that shows up on their MRI, that's the pain. Healthcare providers are frequently more concerned with diagnosis and treatment than providing biological explanations for chronic pain. So if we can educate patients about how chronic pain works, we can really help them focus on their pain, but also acknowledging that, yeah, I know your pain is real. Your pain is absolutely real, and helping them deal with it. So the most important factor in achieving a positive patient and physical therapist interaction is the therapist's ability to explain the treatment. The treatment recommendations in a way that's consistent with the patient's existing beliefs about their pain. If you tell them, I could massage you all day and it's not going to change your pain, but if we come up with strategies that you can use, if you can explain that to them in a way that is consistent with their beliefs about their pain, they are going to get better. So the way we treat chronic pain patients can make the difference between improving their pain and not making any difference. It's a huge, big deal.